Welcome. It is a delight for me to welcome you to the first IgG4ward Fireside Chat. On December 15th, 2023, we really wanted to begin our educational content this year, and it is a pleasure to do that with this Fireside Chat. I'll introduce my guests in a moment, but first, let me say I am very pleased to let you know that we have more than 200 people attending this Fireside Chat, and the recording of the Fireside Chat will be available on our website. So you can go back and review it and let your friends know about it as well. So welcome. We'll get right into this. So Fireside Chats actually have a wonderful history. The term, of course, denotes just sort of a cozy conversation, but they've actually been very important in history as well. This is Franklin Delano Roosevelt. Take a picture of him taken in the 1930s at one of the Fireside Chats. He started these Fireside Chats at a time of great disruption in the world. The stock market had crashed, leading to the Great Depression. Unemployment was very prevalent across the world. There were dust bowls in the Midwest. It was a very scary time. Of course, we have our own problems today. And if you have IgG4 related disease, then the problems of the world weigh even more heavily on your shoulders. So we really hope to bring some comfort to you and some education about your condition. And to be the source of truth, or a source of truth, for patients with IgG4 related disease. So that's what this is all about. I also will say that for the guests that I'm going to introduce, and for me, this is a wonderful pleasure to be able to do this. Out of the many things that we do in the course of our workday, actually getting to share our insights with patients is really one of the things that we enjoy most. So we are also very happy to be here today. So I am delighted to introduce Dr. Arezou Khosroshahi, now of Emory University, and Dr. Emma Culver from Oxford University. Arezou is a rheumatologist, as am I, and Emma is a gastroenterologist. Both of them have been involved in this field for a long time now. In fact, this is a picture that shows the very first International IgG4 related disease symposium that was held in Boston in 2011. And here is Emma present at that very first symposium, and here is Arezou. So they have both been involved in this for a long time. They have seen hundreds or thousands of patients and bring a wealth of experience to what we're going to be talking about today. I will mention in the same breath as this picture that we are now getting ready for our 5th International Symposium on IgG4 related disease, which will be in Milan, Italy, in the spring of 2024, just a few months from now. And we're also beginning to plan a worldwide symposium for patients with IgG4 related disease, and we're targeting 2025 for that. So here's the agenda for today's Fireside Chat. It's really very simple. I will say a few words of introduction about IgG4ward, and then we're going to get right into questions that you have offered to us through the website, and we thank you for those. We will spend the balance of time going over all of these questions. We have taken some time, a lot of time, to think about them and to prepare answers. We prepared slides for the answers with some illustrative figures to help make our answers readily understandable. If we don't have time to get to all of the questions, we will go over a little bit. And if there's just too much material that we're not able to get to, we'll do this again soon. Again, the recording of this fireside chat can be viewed on our website afterwards. So I want to start with the mission statement for IgG4ward, which is to improve the lives of people living with IgG4-related disease through education, expanding disease awareness globally, facilitating groundbreaking research, and being the trusted source of truth for IgG4-related disease patients, their caregivers, and healthcare providers. This is what we hope to do, and I'll talk more about those missions in a second. So here is the board of directors. It's not just the three of us here today, but I and Arezou and Emma are all on our board, which is comprised both of physicians from a variety of specialties as well as by patients. We are joined on the board by Professor Wen Zhang from Beijing, China. She is a rheumatologist. And by the Bambers, Michael and Linda Bamber from Georgia. Michael is a patient and Linda a caregiver. Professor Yoshia Tanaka from Japan, who is a rheumatologist. My colleague at MGH, Dr. Corey Perugino, who is a rheumatologist and a basic scientist as well. Dr. Matthias Löhr, Professor Löhr from the Karolinska Institute, who is a gastroenterologist in Sweden. Mr. Raymond Ewan from Los Angeles, who is a patient. Mr. Henry Danforth from Washington, D.C., who is also a patient. Emmanuel Della Torre, who is the co-host of the 5th International Symposium on IgG4-related disease in Milan, Italy. Emmanuel is an allergist, rheumatologist, and Dr. Sean Nair, also a patient who resides in Florida. So this is the board of directors for IgG4ward. A quick bit about our structure. I am the executive chairman, or the president, if you will, and I lead the board of directors. We will, in time, hire an executive director who will fulfill the role of treasurer and secretary. I am doing that, doing those roles now. We've also begun to think about and identify, in fact, a director for patient advocacy. And now that our funding is really beginning to come together, we will proceed with that early in the new year. And we're also beginning to add key administrative staff to what we do. So we have made great progress in a very short time. A little bit more about our missions. The most important is education, and that is what we're doing today. We hope to educate in a variety of ways, but certainly webinars like this will be an important thing that we do. We intend to raise awareness about IgG4-related disease through any means possible, through publications, through social media, through meetings, however we can make people more aware of this condition. It's very clear to us, and we have been told by many patients, that we need to be able to link patients to physicians who know something about IgG4-related disease. We plan to do that. We ask for your patience with that, but we are making plans to do that through our website in a variety of ways. We have a lot of creative ideas that I think will be successful in helping to facilitate that mission. We also recognize that we need to grow the number of experts on IgG4-related disease, not only in the United States, especially in the United States, where we have a relative dearth of experts, but also throughout the world. And we are working on that and making considerable progress, I think. And then finally, we think that we can facilitate research in this condition in a variety of ways. We will only get to better treatments and cures through research. And we think that IgG4ward can play an important role in that as well. So we have begun to plan for 2024. As many of you know, our launch was only about a month ago at the American College of Rheumatology in San Diego. So a lot of work went on in the several months leading up to the launch, but now we're thinking about planning for 2024. Website expansion will be a big part of this. You have seen perhaps our website version 1.0. I can assure you that it's going to be growing very quickly. So go to it often and share its contents. We will be developing a program, a roadmap of podcasts and webinars and fireside chats. We anticipate that we will have these fireside chats quarterly, but we welcome your feedback, particularly what you would like to hear about. And at the conclusion of this fireside chat, you will receive a short 7 or 8 question survey that we would love to get your feedback on. We will also be developing content for caregivers, particularly when we have our Director of Patient Advocacy. And we'll develop seminars for healthcare providers, recognizing that not only do we need to educate patients about this, we need to educate healthcare providers, doctors as well. We anticipate that our social media efforts, which I think have been very successful so far, will continue to grow, and we invite you to participate in those to help us spread the word through social media. We plan to cultivate opportunities to collaborate with industry and with other foundations. There are many opportunities there, and we'll be diving into those in a big way in 2024. And as I indicated, we've begun to draw up ideas for a worldwide gathering of patients in 2025. So more to come on that. So please give us your ideas. We welcome your feedback. This is really about you. It's about patients. So let us know how we can help. So we're going to get right into it now. And we have at least an hour to get through our questions. So I'll read the first question and then ask Emma to give us her thoughts on it. So the question is, my disease attacks my bile ducts by clogging them with sludge. I've had pain continuously for 15 months now, and IgG4-related disease was finally diagnosed a few months ago. My doctors here are baffled. Any ideas about how to help, Dr. Culver? You kindly provided this illustration to help illustrate your answer. So I'll turn it over to you, Emma.
Thank you. And thank you for that introduction as well. So I think this is a really important question. And pain is a really impactful symptom that can really change the quality of life of people. So I've tried to illustrate it with a figure here. And the figure is of the liver, which you see as the big organ in red. The bile ducts, which are the narrow tubes that come down from the liver and also go out of the gallbladder into the small bowel. And what we tend to find within these tubes is that you can get disease that causes narrowing or strictures of the ducts. And that's highlighted there by the little figure at the top with a round circle around it, where you can see a narrowing throughout that bile duct. And what happens in the walls of that bile duct is you get these inflammation cells, and these cells that are inflamed are caused by the IgG4 process. And when you get a narrowing, you can get things that are stuck behind that. And anything that stretches these bile duct walls can cause pain. Indeed, anything that stretches the outside of the liver capsule can cause pain. And so what we tend to find is that sludge that comes from the gallbladder itself or sludge that's within the duct can cause significant pain and discomfort within somebody's abdomen or somebody's liver. So how do you treat that and what can you do for it? Well, you can see on the right-hand side there's a picture of a small tube that's placed within the bile duct or narrowing. So one way we can help it is to put a small plastic or metal tube in called a stent. And that stent helps to open up the narrowing in a short term, at least, allowing for medication to have its effect to try and get rid of some of the inflammatory cells to open it out. Obviously, trying to allow that bile and the sludge through usually helps with symptoms, but in the meantime, you can take simple painkillers and actually often take things that can help with the spasm of pain in order to try and relieve the pain while you're waiting for those medications or that tube, that stent, to work. So hopefully that's helped to answer the question. And hopefully by treating the underlying condition, it will help with the symptoms that are attributed.
I think that is very helpful, Emma. Thank you. One of the challenges we face with IgG4-related disease is that there's so many different organs that can be affected, but certainly the pancreas and the bile ducts are often affected together, and they are arguably the most important organ or set of organs overall in this disease. Let me ask you a quick follow-up question. Does a stricture inevitably imply that the disease is active, or can they be seen in situations where the disease is not active as well?
Yeah, it's a really important question. So the bile duct strictures can occur in patients who have both active disease, but also in patients who have more scarred disease, what we call fibrotic disease, because they can be there for a long time. And in this situation, sometimes we have to leave the stents in for longer periods of time in order to be able to change the structure of those narrowings and strictures. And the strictures don't just occur in the bile ducts, they can occur in the tubes that supply the kidneys, called the ureters, and they can occur elsewhere as well. So you're right, it can be both the active disease, but also chronic fibrotic disease or scarred disease that can be there for a long time.
And ideally, once we've instituted effective medical therapy, we're able to get these stents out pretty quickly. Is that usually your practice? Completely
the case. So really, we would like to get those stents out, if we can do, within a month to 6 weeks. And particularly as the inflammation starts to resolve, the stents will often fall out, or they can be taken out separately. Except for those patients, as I mentioned, where it's more fibrotic, when actually you might try to take the stent out, but you might have to put another one in its place because it narrows up again. And that might need a longer stent insertion or a different type of stent insertion in order to be able to hold it for longer.
Thank you. So these points that Emma is making are really very important for rheumatologists to hear about as well. And it underscores the point that a variety of different specialists participate in the care of patients with IgG4-related disease. Let's move to the second question now. And Arezou, this one is for you. So let me just talk before reading the question about the image here. So this is an abdominal CT scan, and here where the arrow is the aorta. There is inflammation around the aorta, a periaortitis. These are the renal vessels, and the inflammation in this problem typically begins below the vessels to the kidney and extends down to where the aorta splits into the iliac arteries. So this is retroperitoneal fibrosis. And the question is, my brother developed retroperitoneal fibrosis caused by IgG4-RD and has to get the stents in his ureters replaced every 3 months. Is there some other treatment approach? So stents here come up again, and this is why these stents come up, why they are needed in this problem. This is a CT scan looking up from the patient's feet toward the patient's head. Again, this is the abdomen. Here's the aorta, and here's the inflammation all around the aorta. This periaortitis can reach out and grab one of the ureters, which course from the kidney to the bladder, and they cross the iliac arteries. If I go back here, go back here for a second. Here is the bladder, and the ureters come out of the kidneys and go down to the bladder in this fashion. They can be trapped by this periaortitis, leading to a condition called hydronephrosis, which can lead to kidney damage, as well as a lot of pain. If the ureters are too blocked to permit the passage of stents, then patients often have to have nephrostomy tubes placed into the kidney through the skin. And this is a big problem with quality of life, among other things. So Arezou, I'll turn it over to you now. How do you handle this kind of problem in retroperitoneal fibrosis?
Thank you, John, and thanks for this question. This is a very challenging condition, and I know many patients deal with this and see urologists for multiple stents and multiple urostomy, nephrostomy tubes. It's actually very nice that we have the background. We just heard about the strictures in the bile ducts very similarly, but this is external pressure. So the mechanical pressure that you get from these extra tissues that Dr. Stone just explained presses and closes down or causes narrowing of the flow of the urine from kidney to the ureter. So what needs to be done usually urgently to make sure that the urine goes from kidney to the bladder and doesn't flow back to the kidney and cause damage, the urologist go in and put the stent very similar to what you saw in the picture before to open up that tube. And when they do that, after it's time to really treat the disease. Majority of the times, what you see here that is causing the mechanical pressure and stricture is due to inflammation from IgG4 related disease. And treatment usually takes away the inflammation. So steroids, and then after that, it's other immunosuppressive medications. If patients have a good response to the steroid, they can move on to other medicines to reduce inflammation and remove the pressure that is causing the stricture there, and it opens up, and then they can remove the stent. Sometimes the disease is identified late, it's burnt out, it's a scarring. So, we heard it in the bile ducts, can scarring happen? Here is the same. So if the patient doesn't respond to the steroid, means that unfortunately the inflammation has turned now to the fibrosis and a scar tissue. And that's why the stricture is happening. And in those cases, yes, stents need to be changed and stay there, but they are very rare. What I see in my patients with retroperitoneal fibrosis is majority of them, when you put them on a steroid and after that, medications that we call them steroid sparing or things that we can replace a steroid with, at least the inflammation is resolved and they can open up their actually ureters and they can remove the stent. But you should watch them very closely because many patients still have some scarring there. And as soon as a little bit of inflammation builds up there, again, they're going to have the recurrence. So follow up and monitoring of these patients when their stents are out is very important.
Thank you, Arezou. I am thinking of a patient we shared when you were at MGH. Arezou trained at MGH in rheumatology, and this was a man that we shared, a male patient. He had retroperitoneal fibrosis. He had stents in for 10 years. When we met him, he was on prednisone every day, narcotics, and his stents had been in for 10 years. We treated him with an effective steroid-sparing medication, namely in that case, rituximab. We were able to get his stents out, get him off prednisone, and get him off narcotics. And I still follow him. I've seen him within the last month. He's continued to do very well. So as Dr. Khosroshahi was saying, we actually do very well in treating these patients and getting stents out and getting the nephrostomy tubes out. In this patient here, whose picture is on the right, we were able to get these nephrostomy tubes out following treatment. And you can imagine what a huge improvement in the quality of life that was for her. So let's move on now to the next question. Is a biopsy of tissue necessary to make the diagnosis of IgG4 related disease, or is a high blood level enough? So here on the right is a picture from under the microscope of a tissue biopsy. I think this was from my lacrimal gland. All of the brown staining areas represent cells, plasma cells that are staining positively for IgG4. So this is what we see in a biopsy. And in a patient with IgG4 related disease, the pathologist likes to see lots of IgG4 positive plasma cells. This image would have probably 50 IgG positive plasma cells per high power field, very suggestive, but not diagnostic of IgG4 related disease. But how do we evaluate an elevated IgG4 concentration in the blood? This is a big challenge for physicians because an elevated IgG4 concentration does not necessarily mean that the patient has IgG4 related disease. We get consultations like this a lot. So when I get such a consultation, I ask 3 questions. Number 1, how high is the serum IgG4 concentration? The higher it is, the more likely it is that the patient has IgG4 related disease. But even patients with a normal IgG4 concentration can have that diagnosis. The second question to ask when confronted with a high serum concentration is there a typical IgG4 related disease organ involved? And I'll show you what those are. And then number 3, is there another potential explanation? So first of all, how high is the serum IgG4 concentration? This is a bit of data that is worth keeping in mind. It's from a collaboration between our center and Stanford. It was published just a few months ago, and we examined the patients who had an elevated serum IgG4 at our institutions combined, and even those patients who had elevations of serum IgG4 more than 5 times the upper limit of normal, 25% of those had another diagnosis. They did not have IgG4 related disease. So that is important to remember. Just an elevated serum IgG4 concentration does not mean that the diagnosis is IgG4 related disease. The second question to ask, does the patient have a typical organ involved, or is it just elevation of IgG4 in the blood? So what is a typical organ? The group of investigators from around the world who put together the ACR-EULAR classification criteria for the disease identified these organs as being typical of IgG4 related disease. So first of all, IgG4 related disease tends to involve glands. These are the organs that make hormones throughout the body, hormones and other things. So the lacrimal gland, which make tears, and the parotid and the submandibular glands, which make digestive juices. This is an illustration of the lacrimal gland enlargement. And here is a patient with parotid gland enlargement. And here is a classic picture of bilateral submandibular gland enlargement. But it's not only the glands that can be involved in IgG4 related disease, or it's not only these glands. The pancreas, a crucial organ for making insulin for normal glucose metabolism, blood sugar metabolism, is a gland, and it is affected by IgG4 related disease. And the thyroid gland and the prostate gland and the pituitary gland can also be affected. So the disease has a tendency to involve glands, and we look for signs of glandular involvement when considering IgG4 related disease. But in addition to that, there are the orbits, and orbits is an anatomical term which refers to the areas around the eyes. So here's a CT scan of a patient with orbital involvement, and you can see, again, you're looking up from the patient's feet toward the head here. So this is the right eye, and the right eye is bulging out, a condition called proptosis. It's bulging out because the extraocular muscles shown here and here are enlarged and thickened, and that forces, it's one of the things that forces the eye out. So this is orbital involvement. The lungs and the kidneys can also be involved. The aorta and blood vessels can also be involved. IgG4 related disease, it turns out, is actually a form of vasculitis. The pachymeninges, which are the coverings of the brain and spinal cord, the central nervous system, can be involved in a small number of patients. And the retroperitoneum, which Arezou has already spoken about, is a major manifestation of IgG4 related disease. So when evaluating a patient with an elevated serum IgG4, if one is going to make the diagnosis of IgG4-related disease, one wants to see evidence of involvement of one of these organs. And then finally, is there another cause of the elevated serum IgG4? And there are a lot of different causes of elevated serum IgG4. So allergies, eczema, and asthma, other immune-mediated conditions can all be associated with at least a mild elevation of serum IgG4. So all of this can make it challenging to evaluate a serum IgG4 concentration. And I just underscore the fact that an elevated serum IgG4 is not sufficient for the diagnosis. So moving on to the next question, if there's nothing to biopsy, how would you make the diagnosis of IgG4-related disease? And this is sort of our diagnostic framework when trying to figure out whether a patient's got IgG4-related disease. And this is how we approach the diagnosis of just about anything, really. We consider the clinical features. What are the patient's symptoms? What are the signs on physical examination? We consider the evidence from serological studies, such as IgG4 and other blood tests that can be helpful in excluding IgG4-related disease. We consider evidence from radiology studies, chest x-rays, CT scans, MRIs, and when evidence from biopsy, information from biopsy is available, then we consider that as well. We put all of this information into our diagnostic thinking, and we exclude common mimickers of IgG4-related disease, and there's quite a list of those. And we have to do all of that in order to be confident about the diagnosis. So it's not an easy process, but there are many cases, as this question implies, in which it's not possible to get a tissue biopsy. But we still, even without the availability of information from pathology, we can still consider the clinical, serological, and radiological features. Then, if we think it may be IgG4-related disease, we can treat and observe treatment. And if we see the intended treatment effect, then that provides additional support for the diagnosis. Arezou, here's another question for you. What vaccines are important for patients with IgG4-related disease?
That's a great question. So patients with IgG4-related disease require medications that suppress their immune system. Usually at the beginning, we talked about like steroids, and after that, other immunosuppressive medications commonly used is rituximab, which takes away the B cells that are actually the most important part of the immune system to respond to the vaccines and fight off the infection. So I usually, when I see my patients in preparation for their treatment, ask them to be up to date with their routine age-appropriate vaccinations based on CDC recommendations. So that's very important to actually be compliant with the CDC recommendations for their age-appropriate vaccines. And also incidence and, frequency or severity of the diseases that can be preventable by vaccines can be higher in these patients because their immune system is suppressed. So, for example, if they get influenza, their influenza can be more severe. So I usually recommend seasonally they receive their influenza vaccine, their pneumococcal vaccines, which is currently PCV20 or PCV23, zoster, or shingles, COVID vaccine, and RSV, which is the newest one. So these are what I usually recommend, but of course, based on CDC, hepatitis B vaccinations and others are also recommended.
So the COVID pandemic in particular really changed things a lot for physicians who take care of patients with immune-mediated diseases. And so patients who have to be treated with steroids and with B-cell depletion agents such as rituximab, all of these things really make vaccination a very important part of what we do. I think it's made us much more aware of the need to make sure that every patient is vaccinated for these things whenever possible. As controversial as sometimes vaccines are, for patients with IgG4-related disease, it's very important to make sure that you're up to date on these vaccines.
Another note, John, to add is when the patients get rituximab and their B cells are gone, their immune response to vaccines is not as good as patients who don't receive rituximab. So it's very important to time the vaccines correctly. So either it should be before they receive the rituximab or wait 5 to 6 months after the rituximabs when their B cells are coming back. So timing of these vaccinations should be discussed with their rheumatologist or their treating physicians.
I couldn't agree more. We spend a lot of time talking about the choreography of vaccines and when those are administered with regard to treatment of IgG4-related disease. Very, very important.
Can I just ask as well, just as we're on that subject, at what time between giving corticosteroids and, for example, disease-modifying agents would you recommend vaccination? Because, of course, we've talked there about B-cell therapy, but do you feel, Arezou, that there's a particular time point between giving steroids and immunosuppressive medication when you should vaccinate, or do you not think it matters?
No, that's definitely a very important consideration and good question. So with the prednisone, we have data in other diseases when steroids are equivalent to the prednisone are higher than 20 milligram, your immune response to vaccines are also very low. So the best time is if their steroids are being tapered below 20 milligram, but before they receive the rituximab. Sometimes it's hard. Sometimes you can't find that time, and it may be just the first time that you are giving the patients the medication, they don't have the best response to their vaccine. We usually recommend them to go ahead and get it because although they may not have a good immunity, but they may have better than nothing, but the vaccine can be repeated when their immunity is back.
And there's good data from rheumatology patients, Emma, who've been treated with methotrexate, that even methotrexate can interfere with response to vaccines. I imagine the same is true with MMF and azathioprine and things that you might be more inclined to use in gastroenterology. But as Arezou said, even if the patients are on these medications and you can't stop them, it's still worth vaccinating them because some immunity is better than no immunity.
Yeah, important message. Thank you.
Okay, here, Emma, here's a question for you about steroids, the most commonly used agents in treating IgG4-related disease across the world. In fact, even in the United States, where we have more access to biologics than many countries, 85% of patients still get steroids as their first line of therapy. So the question is, can high doses of intravenous steroids, for example, methylprednisolone 250 milligrams a day for 3 days, that's a big dose a day for 3 days, followed by rapid tapering, help reducing overall steroid-related adverse events while maintaining the same efficacy as lower doses of oral daily steroids for longer periods of time? Very sophisticated question, I think you'll agree.
Yeah, completely. And actually a really good question to have to think about. So I suppose that this alludes to 2 points, I think, for IgG4 disease. One, which we will go on to talk about a little later, is steroid toxicity and the importance of steroid toxicity. Because as you've said, we give lots of corticosteroids or prednisolone predominantly for patients who have IgG4 related disease. But actually, that can cause significant toxicity. And the second thing is really with regards to the fact that IgG4 disease is often a more indolent or slowly progressive disease. And we do see some patients who have more severe or more urgent disease, but that's in the minority of patients. And so we have to think about whether we need to give oral corticosteroids here or intravenous for which presentation. So there is some data looking at other autoimmune diseases where there have been randomized trials and trial data where we've looked at intravenous steroids, for example, in vasculitis or in orbital thyroid disease. And there's also been some retrospective and smaller studies in patients who have IgG4 disease, including going back to sort of 2015, where we've looked at bile duct and pancreas involvement, where they got a very similar regime of IV steroids followed by taper versus oral steroids. And actually what you found is that it didn't really change the long-term outcome and relapse rate. So if you looked at the relapse rate over 3 to 5 years, it didn't seem to make a difference in terms of relapse rate, at least in these smaller studies, as to whether or not you gave IV or you gave oral corticosteroids. And then more recently, there's some data in the ophthalmological area where we do get sometimes very severe disease that can come on very urgently. And in those patients who got IV steroids, a longer taper than described here in a slightly higher dose versus oral steroids, actually they had a better response and a better relapse-free survival, but many more side effects or many more cumulative adverse events related to steroids over time. So I think it's a little bit of a balance of how severe the disease is and also obviously your choice of corticosteroids based on that. I think we really like to do some better randomized trials to answer that question because I don't think we have the data available. But my personal opinion of this, and I'd be interested to see what yours is in those patients where you've got really urgent critical disease, like, for example, sight-threatening disease that can involve the orbital nerve, then hitting hard and fast with something like IV methylprednisolone may be a very good idea. Whereas in patients who've got slightly more indolent disease that, require some corticosteroids, but we can add on second-line immunosuppressives early, would be less, it would be less valuable to use that approach.
I agree completely. Yeah, there's Arezou, you first.
Yeah, I mean, it's definitely, we need more data. And a lot of the times we use those IV high doses in cases that are urgent and critical. But really based on, because we are scared that the patient is going to have critical organ damage. But the efficacy, I'm not sure if it's really needed to do that, because what I'm seeing with my patients with IgG4ward is they have pretty good and rapid response to even lower dose of steroid than what it's suggested here. So by 1 milligram per kg or like just 60 milligram, usually they have a pretty good response. It's a different scenario if there is, you want the IV because the patient has bad pancreatitis, they can take their pills, or they are hospitalized for aortitis. You want to do a faster IV treatment for them. But in cases that I've seen, a majority of them respond well to lower doses of the prednisone. I usually start with 40 milligram. In cases, very severe cases, maybe 60, but not that high, because we see in other rheumatologic diseases that are organ threatening and we use high dose methylprednisolone IV. It may have faster improvement, but at the same time has significant side effects, including a vascular necrosis of their hips and other things that is adding up to the chronic steroid treatment.
So steroids have been, fortunately, have been available to us for 75 years as being really the first things we reach for with serious inflammatory disease. But there's a lot that we still don't know about the optimal way to use them. And I often tell my patients that steroids are exactly the wrong thing to have to use in IgG4-related disease, because the disease affects middle-aged to elderly individuals. It targets the pancreas, which makes insulin and makes the impairment of which makes good glucose control difficult, causes diabetes. And to have to use steroids is an unfortunate reality still for too many of our patients. So we need randomized trials to develop new therapies that will allow us to use less and maybe ultimately no steroids longitudinally for our patients. And that's on the agenda. That's on the research agenda. There is a little bit more than you can hear about steroids on our website. Wen Zhang from Beijing, the Peking Union Medical College Hospital, and I did a podcast about steroids in IgG4-related disease, and you can view that on our website. It's intriguing. She speaks in Mandarin, and there's subtitles to make it easy to follow. So I encourage you to have a look at that on our website. Arezou, another question for you. Does IgG4-related disease sometimes just go away on its own?
That's a great question. I wish I had a better understanding of the true natural history of IgG4 related disease for a long period of time. But majority of the cases that we follow, they have required treatment. So they haven't been off treatment to see if it goes away on its own. We don't leave them off treatment because we know the disease is disrupting the organ function. So we would like to treat them. But I hear from my patients, many of my patients who tell me that, for example, this picture that you see here, that the patient has had a lump in their neck many years ago that went away on its own, and they didn't have any other problems until they came back with another manifestation. So with this, we see this course that sometimes the disease can go away on its own, but doesn't mean that it's completely gone. Probably it's slowly causing a little inflammation. And as you mentioned earlier, it's a very indolent and a slow-growing disease. So I would say if someone has been diagnosed with IgG4RD and then it went away without a treatment, the best way to make sure it's not active somewhere else is just to make sure they have monitoring and follow-up with their doctors. I do have a couple of patients that I've followed them for many years because of the biopsy of their gland showed IgG4RD, but they didn't have any systemic disease, so they didn't require much treatment, and they haven't had any issues yet. But for me to say it's completely gone away on its own is too early. I don't know how you two feel about it.
Emma, do you have thoughts?
Yeah, I think you're right. I think you need to monitor these patients. So similarly, I have a few patients who we've been monitoring whose disease seems to have vanished temporarily, and then one patient who then presented out of nowhere 5 years later with pancreatobiliary involvement, so involvement of the pancreas, so developed diabetes, and some of the things we'll talk about later where they lost the digestive enzymes in the pancreas. And even though we were monitoring them very carefully, actually, it kind of insipidly came on in the background, which raises the question about how you monitor these patients in terms of whether it should be clinical, taking blood tests, or imaging. And I suppose the other thing to say is what we're trying to do is prevent damage over time. So I think we should be monitoring those patients carefully. And the ways in which we do this and the biomarkers we use, I guess, are under constant evaluation, and we're working hard to improve those. John?
Yes, we'll talk about that more as well later on in this chat. I've also seen patients who had submandibular gland disease that went away, and then 10 years later, the disease came back in their kidneys and led to significant kidney involvement. So most inflammatory diseases with our current therapies, we don't cure. But with IgG4 related disease, and this is the really hopeful thing, we can treat the disease effectively and monitor closely. And for all intents and purposes, our goal is to make the patient feel like they are not sick. But we can never forget about this diagnosis and believe that patients are cured. They do need to continue to be followed. So along the lines of following patients, here's another question for you, Emma. Do IgG4 related disease patients need complete body scans once a year to check their main organs?
Yeah, I think this leads on nicely compared to what we were just talking about before. So I guess you alluded to before that we make the diagnosis with a combination of things, and we've talked about the signs and symptoms that patients have, as well as doing the blood tests that look for IgG4. It might be that we're looking at liver tests, or we're looking at kidney tests. And then again, also by looking at imaging and sometimes requiring a biopsy. Now, there's different ways we can do scans. We can either do a PET scan that you can see in front of you there. So a PET scan is where we kind of look at hotspots of disease activity. And on the scan, you can see at the top, if you look at the whole body scan, you can see at the top in B, where you've got some hotspots in areas of the submandibular glands. Next, you can see there's a little hotspot in the tail of the pancreas there on the right-hand side. Below that is a hotspot in the ureters around the kidneys. And below that, I believe that's a hotspot around the prostate. So we can see hotspots on PET scans, but PET scans are radiation inducing. And actually doing an annual scan on a yearly basis gives you a lot of radiation if you were to choose a PET CT or even to choose a CT scan. There are alternative options like MRI, but that isn't great for every organ and it doesn't necessarily pick up disease. So I think there's a couple of questions there. One is if we can pick up a disease activity and the best way to do it. And two, what's the merit of treating a little bit of activity in a scan when it's not associated with clinical symptoms? And do we know that that goes on to cause damage? And I think they're slightly different questions, but both really important to think about, because actually our current practice is very much in those patients at least who have a biomarker like the IgG4 level, which we're going to talk about later, which we can track over time, to get an idea regularly of patients' symptoms, their signs, if there's any glandular involvement, to do the blood tests we've talked about, which are non-invasive, and to track and to mark the IgG4 marker, which might give you the route into doing a scan, as opposed to doing annual scans, which are associated with potential radiation. And we don't necessarily know, even if we pick up an area of a little bit of hotspot or activity, what that actually means as to whether or not that means that area is going to get damaged over time, or whether that means that that's going to stay the same and it's not going to change and it's not going to affect the clinical outcome. So my personal opinion, I guess, taking all of that is that currently we're not in a situation to say that we should be doing annual scans for all patients. There are a subset of patients that you might not be able to detect on this IgG4 biomarker or clinically, like, for example, retroperitoneal fibrosis, where you may want more regular scans than someone, for example, who's got head and neck disease, where you can see it more actively. And then I think the second question is the choice of scan if you are doing scans, and we should be trying to evolve ourselves to those that have the least radiation and the least impact over time on patients. And in those patients, we can do MRI. That's obviously a good option. What's your thought on that?
Emma, you sound like you've taken care of a few of these patients.
I have indeed, and it's a challenge.
Yeah, I'm very pleased to hear your answer. It's exactly what I do, and there's a lot of nuance to taking care of a patient with IgG4 related disease. There are some patients who have a particular organ involvement, maybe retroperitoneal fibrosis, in which some regular imaging makes a lot of sense. But most of the time, I do not use regular imaging to follow patients. Arezou, what about you?
It's variable patient by patient. As you said, there are some patients that if you know that their serum IgG4 is elevated, so there should be disease somewhere. And if you can't find it on your exam or on other labs, I repeat their scans or at the beginning of the disease just to understand it better where they have involvement. But I completely agree with you guys that repeating just because it's a patient that I see once a year to do the scan, I don't do that. There are some risk associated definitely with radiation. There are some things that we find on the scans that just doesn't make sense, or interpretation of those is going to be very difficult for patient and the provider and is not helpful. But as needed based on the physical exam and labs, some patients require that.
Thank you. We'll talk a little bit more about following patients with other ways in a bit. So the next question really is a nomenclature one, a vocabulary question. And one of the goals that is important for IgG4ward to help achieve is a good patient vocabulary for how physicians talk about the disease. So the question is, what does a flare mean? And flare is physician speak, really, for a recurrence of disease activity. It means that the disease is active. Typically after after a period of disease control, we might call that remission. We don't call it cure, but if there is no evidence of active disease, we call it remission or remission on treatment. And when the disease has recurred, we use the word flare. So the second part of this question is, can fatigue be an indication of flare? And absolutely, it can be. I'm often struck by patients who tell me that the very first thing they noticed was that their energy sagged. And this was weeks or months before they were diagnosed with IgG4-related disease. We don't understand all of the contributors to fatigue. There are many. Dysfunction in any of a variety of different organs can lead to that, potentially. But IgG4-related disease is a systemic disease. And even if there is evidence of involvement of only one organ, it's still a systemic disease. The immune system is revved up in a systematic way. And this can lead to fatigue in ways that we don't fully understand. Treatment typically leads to improvement in fatigue, but in many inflammatory diseases, the fatigue is really the last thing to get better. I also think, and I'm curious to what Emma and Arezou think, that fatigue may not be an indication of flare. So it is not invariably associated with flare. And before attributing fatigue to flare, I want to see some other elements that suggest a flare, a rising IgG4 concentration or abnormalities in other organs. Arezou, Emma, do you have thoughts about fatigue in this disease?
I can't agree more with you in terms of fatigue is such a non-specific symptom, and we all get some fatigue once in a while, or a lot of our patients get that symptom. So it shouldn't for sure mean that this is a flare, but it's a good marker to evaluate the patient to see what's going on, if it is related to their IgG4D flare or it's related to something else. I recently had a patient with IgG4D who was experiencing significant fatigue, and that's a patient that usually doesn't have this symptom with his activity of the IgG4D. Evaluated him, and he had developed a significant low function of his thyroid. So there are multiple other reasons that can happen and cause the fatigue, but it's a good sign to be evaluated thoroughly with their physicians and understand if it is related to IgG4D or related to something else.
Yeah, I would agree. And I would also kind of add on, I guess I tend to do a sort of almost a fatigue screen when anyone tells me they have fatigue, because it is such an impactful symptom and it's something that can completely control patients' lives. And that fatigue screen, as you mentioned, Arezou, really includes thinking about other autoimmune conditions or other things that can be causing fatigue, getting an idea about sleep patterns, and particularly corticosteroids, because steroids can cause you to have insomnia at high doses, can cause mood disturbance. But also, if we reduce them too quickly, sometimes you can get adrenocorticoid insufficiency, and that can be associated also with, significant fatigue. And I've had patients who we haven't reduced more cautiously enough, and going down less than 5 milligrams have had significant fatigue, but actually their cortisol is falling. And so I think you have to cast the net wide when we think about that, and we have to exclude other things, treat what's treatable, and don't forget steroids as a cause at the high dose end, but also at the low dose end of contributing to that important symptom.
Very good point. So let's move on to the next question, which is, I lost 40 pounds before my IgG4-related disease diagnosis was made, and I still can't gain any weight back, even though I've been on prednisone. And this is a patient who might have written this question. You can see what we call temporal wasting. The patient has lost a lot of weight. So what is going on? Emma, this sounds like a question for you.
Thank you. And I guess in this kind of context, weight loss can be very much multifactorial. I mean, of course, we can relate it to the underlying inflammatory process, but for that, he's getting prednisolone. You can relate it to the underlying insufficiency of the pancreas, and I'm going to talk about that in a moment. But it can also be associated with other autoimmune conditions. And we know in patients with IgG4 disease, anywhere between 10 and 15% can have another autoimmune condition. So I think, again, we have to cast the net wide. So we know that one of the most frequent involved organs in IgG4 disease, even if it's not swollen at the time of diagnosis, is the pancreas. And the pancreas can be involved in anywhere between a third and a half of cases. And you can see in the nice radiological image in front of you with the box around it, That's a very swollen, sausage-shaped, diffusely inflamed pancreas. But what happens over time, either with treatment when you're in prednisolone, or sometimes independent of that, is the pancreas tends to shrink and it atrophies. And as the pancreas tends to shrink, it can actually start to lose its function. It can also lose its function when it's actively inflamed also. And the pancreas has probably two main roles, and we've alluded to them before. One of them being the hormone replacement, and that's associated with things like diabetes and glycemic control. And the other thing is also to think about digestive enzymes, and it produces lots of digestive enzymes. And those digestive enzymes are really important in order to be able to break down your food and release certain things. So the sort of things it produces are lipase, which breaks down fat, protease, which breaks down protein, and amylase, which is important for carbohydrate. And so what we find in lots of patients who have IgG4 related inflammation is they may have subtle involvement of their pancreas, even though that may not be the first organ that it presents with. And you can get a degree of malabsorption because actually you're not absorbing the vitamins that you need. For example, the fat soluble vitamins, which are A, D, E, and K, and that can lead to significant weight loss. And alongside that, some patients will have loose stools that float on the surface of the water and oily, what we call steatorrhea. And they can also experience some other symptoms of losing those fat-soluble vitamins, of having problems with A, which can be associated with problems with vision, having problems with B, which can be your bone health, so thinning of the bones, or K, where you have bruising because you have difficulty clotting. So there's lots of other things that can occur alongside the malabsorption with weight loss. And I guess secondly, we've just talked about these digestive enzymes, but talking about hormones, some patients can actually be developing glucose intolerance or diabetes and they're unaware of it. So one of the other big things with weight loss when we first see patients with IgG4 disease is you have to think about whether or not you're processing your glucose appropriately and whether you've got sensitivity or not to insulin. And it can be as those cells that control insulin get knocked out in number or in function, you can lose weight as a result. So I suppose in summary, you can think about it being related to the inflammation, but we're getting steroids for that. You can think about it being an underlying pancreatic problem where you get some malabsorption, and that may be manifest in terms of nutrient deficiencies, but also in terms of glycemic control. And then lastly, you want to look for other autoimmune conditions. And I guess in terms of treatment for this patient, I would be recommending thinking about pancreatic enzyme replacement therapy, thinking about replacing those vitamins with a multivitamin in terms of the fat-soluble vitamins, and thinking about making sure they're on some calcium and vitamin D for their bones and checking that glucose level and any other autoimmune conditions like celiac disease or thyroid disease, which we've talked about before.
Thank you very much, Emma. I like the way you pronounce vitamins. We pronounce it vitamins on this side of the pond, but I think both work. We know what you're talking about. The pancreas is so often hard hit in this disease, and we think most obviously of its tendency to cause diabetes. But in our experience, the exocrine pancreatic function is even more likely to be hit than the endocrine pancreatic function. And these are the patients that just can't gain weight, as the patient who wrote this question. But they do well or do better with pancreatic enzyme replacement. Let's move on. And as I indicated, if we run over a minute or two, that's fine. We have 5 or 6 more questions that I think we can get through in pretty close to the time. Arezou, this is a question for you. Can elevated blood IgG4 level simply be a normal response to a COVID vaccination and not indicative of any pathology?
Yeah, so I think, John, you explained this in your question before. So serum IgG4 elevation alone is not indicative of IgG4-related disease. Many people with history of asthma, allergy, atopy can have elevated IgG4. Specifically, people who receive allergy shots have elevation of their serum IgG4. Normal serum IgG4 elevation without any disease is in beekeepers. I mean, they have the highest levels of IgG4 because they have this exposure, constant exposure to the bee venom. And there actually tells us about like why IgG4 goes up. So it's a part of the immune system that has this tendency to increase the protein when there is exposure to these antigens. In the beekeeper case is the bee venom, in allergies, some type of allergens that come to the body. Interestingly, there was one study showed that people who got repeated mRNA COVID vaccinations, after 3 doses of the vaccine, they had a slight elevation of their serum IgG4 that required about 6 months to go up. So that's a very valid question that this person asked. So it has been actually seen that patients after multiple COVID vaccines can have a little higher serum IgG4, and that does not mean they have the disease, as you showed in your slides before. So if someone has elevated IgG4 but does not have involvement of the typical organs or any masses that they can find on the imaging, most likely it's a normal immune reaction to some exposure to the antigens.
And that
That's a
is
short-
exactly the point of doing the vaccine, right? To stimulate the immune system to be able to recognize that pathogen again. So it doesn't mean that the patient's developed IgG4 related disease. It is a sign, I hope, and it is likely that the vaccine is working and will help protect them from infection.
Definitely. So when we get vaccinated, we usually have increase in our IgGs, different type of IgG, 1, 2, 3 can go up based on the immune response that we have. And that's what the purpose of the vaccine is. In case of COVID vaccination, some patients have had elevated IgG4 also, but that's part of the normal immune response. You're completely right.
Okay, so let's move on to the next question. And the next series of questions, and we'll stay with you for these, Arezou, relate to rituximab, which has played a big role in the off-label treatment of IgG4-related disease for some time now. So there are a number of questions. We should move through them pretty quickly, though, if we can. So the first, is it safe to stay on rituximab for many years, Arezou?
That's a great question. So not our practice or our experience has been that patients require to stay constantly on rituximab as a standing infusions every 6 months. That is the usual practice for some patients with rheumatoid arthritis or vasculitis, but not in IgG4 related disease. It's individually based, and usually we look at the organ involvement, the activity of their immune system. We talked about like how sometimes serum IgG4 or other serum markers can help us to exactly understand what's their load of the disease, what's the burden of their disease, and then we decide that how to treat these patients. In my experience, in my practice, I usually treat patients with 1 course of rituximab, which is usually 2 doses, and evaluate their disease response. Most of my patients do not need to be receiving rituximab again 6 months after. Majority of them may require to get it a year or 2 years after, based on their disease activity, if they have symptoms, if their labs are abnormal, if their serum IgG4 is going up with relation to their disease activity. But I do have some patients that have really, really multi-systemic disease, and I may give them 2 courses every 6 months and then decide to put them in that as needed basis. So I don't think patients require to stay on repeated doses of rituximab every 6 months for many years. That's the short answer.
Yeah, I agree with that completely. And these next 2 questions really are very similar. Is rituximab needed for life after being diagnosed? I think it's certainly my practice that I, like you, Arezou, do not retreat patients every 6 months or at any particular interval, but I follow them closely and retreat them when necessary. And then can we consider patients to be cured if they have been put into what seems like a long-standing remission? And the answer there is, unfortunately, no. I don't think rituximab cures patients. It does make them feel like they're cured and makes them feel that way for a long period of time. But inevitably, the disease does come back, and we have to be watching for that. So let's move on to the next question, and this one is for you, Emma. I became diabetic when I was diagnosed with IgG4-related disease and had to start taking prednisone. Will it be possible for me to get off insulin someday?
Yeah, so I get asked this question a lot, actually. So I think it's a real life, question that a lot of patients are thinking about. And we know that diabetes is common. It occurs in anywhere between 20 and 75%, depending on the cohort you look at, from, Europe to Japan. And we also know that the timing of the diabetes is quite crucial as to whether or not patients can get off and reduce their glycemic control. And so we know in half of the patients who present at around the same time, so their diabetes and their IgG4 disease is diagnosed simultaneously, and a third of patients where it's diagnosed just before, they have more chance of getting off diabetic medication in the longer term than those patients who've had diabetes that has been present for a long time beforehand. And this is partly related to the fact that actually, if you treat the underlying pancreatic inflammation, and it's believed that the pancreatic inflammation is the thing that's causing the exocrine and endocrine insufficiency, which means, in other words, that they're the thing that are taking out the cells that's causing the insulin resistance, then actually you can improve that glycemic control over time. And even patients who are on insulin can go back to not necessarily taking insulin anymore. So there's a sort of rule of thumb I use in my head whereby I say half of the patients will develop it at the same time. And within then, about half of those patients have a chance of being able to reduce their glycemic control, potentially coming off insulin and going elsewhere to other medications. And some patients will completely stop their glycemic control after stopping or tapering off their steroids. And I guess the other thing to say is there are some cofactors that give you a higher risk of staying on that insulin, and that includes smoking. So that's a big thing. And I think that, patients should be actively encouraged to stop smoking in that sort of setting. And secondly, older age patients and those who've got complete atrophy or calcification on their scan are less likely to be able to come off insulin in the long term. So it's possible, but it's about the timing of diagnosis and the treatment.
So it's a great day when we are able to get patients off insulin and declare them non-diabetic, at the same time having achieved effective control of their IgG4-related disease. There is another important mechanism of diabetes and IgG4-related disease that it's important to mention, because this really plays into our mission at IgG4ward of needing to raise awareness of the disease. This drawing was done by the surgeon of one of my dear patients. It's a beautiful drawing of an area very often involved in IgG4-related disease. So I'll just run through the anatomy. Here's the esophagus, here's the stomach, this is the liver. These are the bile ducts that Emma was talking about earlier on, and the gallbladder, the small intestine. This is the pancreas, which inserts into the small intestine. And the problem in my patient was this mass that he had here. And the surgeon was not aware that he had IgG4-related disease and proposed to do the following morning what's called a Whipple procedure to remove what was assumed to be a cholangiocarcinoma, a cancer of the bile duct. Fortunately, the patient's serum IgG4 came back that evening. It was very elevated. The diagnosis was reconsidered, and the patient did not undergo this radical modified Whipple procedure, which may well have made him diabetic. And we've looked at our patients with pancreatitis and IgG4-related disease and found that no fewer than 10% of them have undergone a modified Whipple procedure, which was unnecessary. And this really underscores the importance of making the medical community much more aware of this disease. So we'll move on to the next question. I love this question. We lymphomaniacs are a challenge for our primary care doctors. Will guidance be available to assist PCPs in monitoring for disease flares and identifying disease progression beyond the basic lab work that PCPs usually order? And here again, the question gets to monitoring. And the questioner also adds, grateful for this IgG4ward Foundation. Thank you. And thank you for that comment. It is important to note we always complain in rheumatology that we don't have good biomarkers, and probably the same is true in gastroenterology. But in IgG4-related disease, IgG4 can often be a very good biomarker. And this is illustrated by a patient I saw just earlier this week, a patient I've been seeing for a long period of time. She had been treated with for her pancreatitis even before 2018 and had gone into remission. And here were her IgG4 measurements in May and November of 2018. Then they started to go up, and I didn't do anything at that time point. She was completely asymptomatic, but I did follow her more closely and measured her IgG4 more frequently. She had no symptoms whatsoever, but her IgG4 was rising steadily. And when it got to this level, 3 times the upper limit of normal, not that there's anything magic about 3 times the upper limit of normal, I decided to treat her. And I treated her again here. And following treatment, the IgG4 concentration declined. She never had any symptoms during this period of time, but it was very clear to me that her disease was becoming active again. And over time, fortunately, right at the time of the pandemic, her serum IgG4 was normal and continued to decline after that treatment course. And only very recently, only at the end of last month, did her IgG4 really take a decided swing upward again. And now I've decided to treat her again. Again, she has no symptoms. But through doing this, through careful follow-up and intermittent use of appropriate therapy, we can prevent disease flares. We can prevent organ damage. So IgG4 can be very useful in this regard. We should discuss also the potential downsides of rituximab and B-cell depletion. Arezou, could you give us a quick summary of those?
Sure. Yeah. So we have to see what rituximab does. So we are trying to reduce the inflammation in IgG4-RD by taking away the B cells. So what you see in this picture is actually the B cells from when they come from the stem cells and turn to plasmablast and plasma cells that are major cells in our immune system that make antibodies to fight off the infections or germs that come to our body. Rituximab is a monoclonal antibody that targets specifically CD20, which is on the B cells that are in that kind of rectangle over here. And they will be gone. When patients receive rituximab, the B cells get completely are gone from the blood peripheral or the blood system, and they don't have that function of fighting the germs. So this makes patients prone to get infections. So if they get an infection, one part of their immune system is shut down. So it's not the only part of the immune system. We have other cells in our immune system that are going to still defend us from infections. But one part, which is very important part, B cells, are shut down for this period of 6 months that these B cells are gone. After the rituximab infusions, like about 6 months, not in some patients, depending on their age, 9 months, the B cells slowly come back and they resume the function of the immune system. But interestingly, in IgG4-related disease, the IgG4 has a slower return back when the B cells come back, and that's why patients do well. So the reason I wanted to explain this is just to for you guys to understand that when patients receive rituximab, they are more prone to get infections, and also the B cells are responsible to make immunity when they get vaccinated. So when patients are on rituximab, they don't have a good response to vaccines. We talked about that before. The other thing is it's a monoclonal antibody. Some patients develop reactions during their infusion. People who have received it know that it needs to be a slow infusion, and they need to receive some medications prior to that. That also has some side effects. One of the longer term issues that we see with rituximab is if they get repetitive doses, multiple over years, that can decrease their immunoglobulin levels, which is those antibodies that we need to fight off the infection. So those are really the major side effects of the rituximab that we see, and that's why we use it cautiously. So we use it for patients because it works, but only if needed, and only for patients who need to get it. I wish that we had a medicine that would work as good as rituximab, but less side effects, but this is what we have so far.
Thank you, Arezou. Well, we are working on those better and hopefully new medications, and we have just about 5 minutes more, I suspect, and we'll talk about the ongoing clinical trials as part of that. The next question is also about rituximab. And the question is, there is no funding for rituximab for my 30-year-old daughter here in Canada. How does she get it to help her live a somewhat normal life? Of course, rituximab, though we use it off-label when we can, it's not approved for IgG4-related disease, and we really need approved drugs so that we can use things other than steroids to treat these patients. In the meantime, it is sometimes possible to get rituximab off-label, and I would have the questioner know that Genentech, which makes rituximab, has a foundation, the Genentech Access to Care Foundation, which has provided rituximab for many of my patients through the years, assuming they meet criteria for receiving it. And another program called the Rituxan Access Solutions, which this questioner might make some inquiries with. Emma, can IgG4-related disease ever be treated with surgery? So the specific question is, I have persistently swollen tonsils caused by my IgG4-related disease. If I were to have a tonsillectomy, would the disease just move somewhere else?
Yeah, so almost two different questions there, but really interlinking. I suppose the reason for the image is to show where the tonsils are. So they're the fleshy things that you can see around the back of the throat. And those fleshy areas are a bit like part of the lymphatic symptoms, or they act a bit like the lymph nodes, and they can become inflamed. And when they become inflamed or enlarged, that can be called tonsillitis. And there's lots of different things that can cause that. And the tonsils themselves being inflamed and lots of other inflammatory conditions can be infiltrated with IgG4 cells. And we heard a little bit before about when serum IgG4 can be raised in lots of different inflammatory and infective conditions. And that's the same for the tonsils. So groups of people have looked at the tonsils, have taken little sections of them when they've been removed and stained them for these IgG4 cells. And in anywhere between 20 to 30% of patients, you can actually see these IgG4 positive cells. That doesn't necessarily mean in that instance that those tonsils are necessarily part of the IgG4 spectrum. However, the answer is if we take away these tonsils, does that take away the disease in somebody who has IgG4 disease? Actually, probably not, because we know that the IgG4 disease and the IgG4 cells are in multiple different lymph nodes throughout the body and potentially, obviously, in other organ systems. Can surgery in other instances help the disease? There are situations, particularly where you have fibrotic disease, so scarred disease, which encases a particular organ system or involves a single organ, where actually removing it is more beneficial than giving high-dose steroids or anti-inflammatory drugs, or in those instances where it's failed. And in those kind of situations where you do have encasement or you do have fibrosis of a single organ, taking away that organ can potentially be beneficial. It doesn't mean, though, however, that the disease is not necessarily going to occur elsewhere. And in patients who have the underlying disease, and we've talked very much about the difference between cure and control, we're thinking about removing the area which is maybe inflamed and scarred, but that doesn't prevent it coming from elsewhere. So taking away an individual organ or an organ system or an area can be helpful in some situations, but that can lead to downstream problems. And also it doesn't take away the underlying disease overall. Do you have any other comments to make about that?
No, I agree with you completely. We try to take a medical approach, medical therapies whenever we can. There are some rare manifestations of IgG4-related disease. For example, when it only involves parts of the aorta and it's discovered at surgery, sort of quite by surprise. Then if there is no evidence of disease in other conditions, well, the aorta has already been fixed, and we tend to just follow those patients. And in those cases, it's possible that surgery does in fact cure them. But most of the time, we need to continue to follow just to make sure that disease doesn't crop up someplace else. So let's close with a quick discussion of clinical trial updates. So clinical trial updates would be appreciated if time permits. We're just a little bit over time, but I will spend just a couple of minutes talking about 2 phase 3 clinical trials now, which we hope will lead to new drug approvals in the next year or two. These would be the first drugs approved in IgG4 related disease. And both of these drugs target B cells. One is called inebilizumab, and the other is called obexelimab. These are long names. I wish we could come up with shorter names for our drugs. But again, they're inebilizumab and obexelimab. Inebilizumab is an anti-CD19 antibody. It is similar to rituximab, which targets another protein on the B cell called CD20. Inebilizumab is a monoclonal antibody that targets a different protein called CD19. And I'll talk a little bit more about obexelimab in just a second. But the inebilizumab trial, the anti-CD19 antibody, is called Mitigate. And here is a quick design schema of the trial. So patients are enrolled at a time when they have a flare. Again, there's that word flare for active disease. They're screened for up to 28 days to make sure that they fulfill enrollment criteria. And then they're randomized. It's a randomized double-blind placebo-controlled trial to receive either inebilizumab or a placebo infusion. And patients in both groups receive steroids, which are tapered off at 8 weeks after the first therapy. The goal is to demonstrate that inebilizumab is successful in inducing sustained remissions at week 52. And then there is a 2-year follow-up period. It's actually a 3-year follow-up period after that baseline visit. So this trial will finish at some point in 2024. So we are looking forward to that with great anticipation. The second trial, the Indigo trial, is of a novel medication which also targets CD19, not only CD19 on the surface of the B cell. Whoops, who knew that there were so many? Let's see. Sorry, my computer's gone a little crazy here. This is a schematic of the surface of the B cell. There are a lot of different proteins in the B cell, but obexelimab targets CD19 and also targets this protein called Fc gamma R2b. And when both of these proteins are bound together, the B cell is not depleted, but actually simply deactivated, helping to control the disease, we believe. And here is the design schema of the Indigo trial. It's very similar to the inebilizumab trial, following a screening period and an induction remission induction period with steroids. Patients are randomized to receive either the active drug or a placebo. Both groups receive the same prednisone taper, and the primary outcome is determined at week 52 with a 1-year follow-up extension period. So this trial, which is also a worldwide clinical trial going on now, may also be completed with regard to enrollment, hopefully in 2024, and may also offer another treatment option for our patients. So we are very hopeful about both of these new molecules, specifically for the treatment of IgG4 related disease. So we're a little bit over now. I will cut short further discussion, but I just want to thank Emma and Arezou for joining and contributing their wealth of knowledge and expertise in this condition built over many years now of taking care of patients with IgG4 related disease. Thank you so much. And I thank all of you for tuning in. You can view this again on our website. It has been recorded. Please respond to the questionnaire to give us your input on this session and tell us what we can, what you want to hear about the next time as well. Finally, happy holidays to you all, and most importantly, healthy 2024. Thank you.